Hi everyone, we're going to talk about Section 7 abdominal pains that begin on page 529 in the book. These slides that are provided by the publisher do not have a lot of detail to them, but they are more the highlights of the book, and we're going to try to get into a little bit more detail in each section of the book. But I encourage you to read the chapter before listening to this audio and have the PowerPoints printed out and maybe be able to take notes that way. We're first going to talk about abdominal pain, and it is one of the most common complaints you're going to see in primary care. And what can be frustrating for the patient is over half patients who complain of abdominal pain do not receive an accurate diagnosis for what their complaints are. But let's start with definitions. There can be numerous causes of abdominal pain. These can be associated with inflammatory, metabolic, or structural. So if someone presents with an acute change in their abdomen, it's very important that that is evaluated promptly. To determine the severity of the condition, it's important to see the total patient presentation when they come to you and get a careful history when evaluating their abdominal pain. You want to know about the onset, the location, any characteristics, any aggravating or associated factors, where it's located, any relieving factors, severity, and what does the pain mean to the patient. You want to know if there's any associated symptoms such as tachycardia, tachypnea, elevation in their blood pressure. You want to know if there's presence or absence of bowel sounds. All patients that present with abdominal pain should have a thorough rectal, genital, and pelvic evaluation. As we talked about earlier, abdominal pain can be caused by a variety of factors. Those could be mechanical, inflammatory, or ischemic, and these factors can give characteristics to the type of pain that your patient may be receiving. On page 529, there are some good definitions on the different types of pains, and we'll talk about those briefly. First is visceral pain, and it's caused by a distension or a spasm in the organ. It's often described as being generalized and dull. You can also have parietal pain, which can be sharp and well localized, and it is caused by irritation in the peritoneum. There is also burning pain, which is caused by irritation of the gastric mucosa, such as in gastritis or esophagitis. Timing of the pain is very important. You want to ask about the onset, duration, frequency, and any relationship to associated symptoms. On page 530 through 532, there are some very good diagnostic reasoning algorithms for abdominal pain, including sudden onset, burning, cramping, and visceral type of pain. I remember as a new practitioner, I had these pages bookmarked so that if I had someone that came in with abdominal pain, I was able to go and narrow down what type of pain it was and go through the algorithm that helped me in determining where my next steps needed to be with this pain. So I encourage you to be familiar with this algorithm. So one of the most common complaints that you will see for both adults and pediatric patients is constipation. And that we know is difficult or infrequent defecation. It's very common in Western society. It's particularly seen in older adults and sedentary individuals. It is often due to lack of dietary fiber. The recommended daily amount of dietary fiber is 30 grams for optimal health, and the average American only consumes about 10 grams of fiber a day. Other common causes of constipation are overuse of laxatives, IBS, not being active enough, changes in travel or their environment, certain medications that have constipating effects, and then suppression of the urge to have a bowel movement or painful defecation caused by anorectal problems. Constipation is divided into three categories: functional constipation, which generally results from low fiber in the diet; disordered mobility, which is seen in older adults due to a slower transit time; and secondary constipation, which is a result typically of medications. And on page 532, in box 38.1, there's a list of medications that commonly cause constipation. The management of constipation is very straightforward. Most patients do very well with education about bowel habits, activity, and dietary intervention. The patient should be instructed to slowly increase the amount of dietary fiber up to 25 to 35 grams of fiber per day, with at least 12 to 15 grams of fiber with breakfast. Exercise is helpful in stimulating peristalsis, and having uninterrupted toilet time is important, along with adequate nutrition and hydration. So the reverse of constipation is diarrhea, and as with constipation, there's no single definition of diarrhea, but it's described as increased frequency, volume, and fluid content of bowel movements over what is normal for the individual. And in practice, it's very important to understand what the patient's definition of diarrhea is. My definition of diarrhea is a watery liquid, like pouring a glass of water into the toilet. Other terms that I use with patients is to describe their stool consistency is like sludge or pudding. So they may view it a soft stool as diarrhea. So I think when you're speaking with someone regarding diarrhea, it's important to clarify what their definition of diarrhea is. There are several different types of diarrhea. The first one we're going to talk about is osmotic diarrhea. This happens when there's an osmotic gap between the stool and the serum is over 50 per kilogram. An increase in the osmotic gap implies either ingestion or malabsorption of a substance that is osmotically active. And osmotic diarrhea usually responds to fasting well. Celiac disease falls under an osmotic diarrhea and can be a malabsorption syndrome related to an immune reaction to gluten in the diet. The gluten affects the intestinal mucosa, causing the villi to become flat, and then the villi are not able to absorb nutrients along the way as food is going through the GI tract. These patients can have intestinal ulcers and nutritional complications. A patient with a history of chronic diarrhea may report foul-smelling stools, weakness, fatigue, abdominal bloating. To diagnose celiac disease, a distal duodenal biopsy is needed to confirm the diagnosis, and then treatment would include a gluten-free diet. A second type of diarrhea is secretory diarrhea, and you have large volumes of watery stool that is unresponsive to fasting. These can come from bacterial toxins, mostly in the E. coli family, and viruses, but it can be caused by laxative abuse. In the book on page 536 and 537, there's a great diagnostic algorithm for diarrhea, so I encourage you to look at that. It breaks it down for diarrhea lasting more than 2 weeks that is reoccurring, watery diarrhea, sudden onset, and other factors that you might need in your working up of someone who presents with loose stool. Next, let's talk about dyspepsia and heartburn. Patients that present in primary care with these symptoms have been decreasing over time as the availability of PPIs and acid blockers are now on the over-the-counter medication list. We also need to understand what the difference is between dyspepsia and heartburn. Dyspepsia includes epigastric discomfort. You can have fullness after a meal. You can feel full early, anorexia, belching, nausea. You can have abdominal burning. These symptoms can be seen with patients who ingest alcohol in significant quantities or take drugs such as aspirin, corticosteroids, NSAIDs, theophylline, erythromycin, and these can occur as a result of medication-induced gastritis. Heartburn is described as a retrosternal burning sensation, and it's very common in the general population, and it's often as the result of GERD. On page 539 in the book, there's an algorithm for heartburn and dyspepsia that I'd like for you to look at to get some more details on it, on presentation and medications. The next condition we're going to talk about is jaundice. You also may hear it referred to as icterus, which is the yellow discoloration of the skin, mucous membranes, and the sclera of the eyes, which results from a buildup of bilirubin in the blood. So you're going to be following your liver function test for these for these conditions, and you're going to be looking for the AST and the ALT to be elevated, as these are good indicators of hepatocyte damage. And elevation in these levels reflect some activity of disease in the liver. A patient who presents with yellowing skin often has complaints of pruritus, anorexia, nausea, vomiting, weight loss, fatigue, fever, and light-colored stools. In the book on page 540, box 38.2, there is information on causes of elevated bilirubin. You can have this related to increased production or decreased clearance, and it gives different conditions and medications that may impact that. Also on this slide, there's a section on melena, which we know is that black tarry stool that's a positive for occult blood. On page 540, there are common causes of GI bleeding, whether it's peptic ulcer disease, esophagitis, esophageal varices from the upper GI tract. From the lower GI tract, you could have diverticular disease, colon cancer, inflammatory bowel diseases. So always be aware of that. But upper GI bleeding is the most common, and that is why it presents as darkness when it finally makes it out of the rectum. That's a good indication that it's an upper GI bleed due to its color. Labs that you might want to assess if you were concerned of someone having an upper or any form of GI bleeding would be a CBC count and the possibility of doing some iron studies to see how long the bleeding has been going on, and then an endoscopy of the upper GI tract may be needed to assess where the bleeding is coming from. Let's talk next about nausea and vomiting. We know that nausea is an unpleasant sensation in the stomach, but it's more a sensory experience. You can have increased salivation, shortness of air, sweating, a vasovagal response with low blood pressure and low heart rate. It can occur alone, or it can precede vomiting. And then we know that vomiting is expulsion of the gastric contents. There are several things that can lead to nausea and vomiting. Those could be GI issues such as food poisoning, food intolerance, lactose deficiency. It could also be CNS related. It could be intracranial pressure or migraine. It could be diabetic ketoacidosis. There is a great box on page 541 that talks about different causes that may be leading to nausea and vomiting. With nausea and vomiting, the main goal is to find the underlying cause and then provide systematic relief. There are medications commonly used for nausea and vomiting that are found on page 543, and also there is an algorithm for nausea and vomiting on page 542. So be sure and review those. So next we're going to talk about dysphagia, which is difficulty swallowing, which may or may not be associated or be a component of odonophagia, which is painful swallowing. Just to review, swallowing occurs in 3 different phases and requires over 50 pairs of muscles and many nerves to accomplish that process. We're not going to go into detail, but it includes the oral phase, the pharyngeal phase, and the esophageal phase, and those are all found in your book. It's important to try to determine what swallowing process is going on so that can help narrow down your differential diagnosis, and that will be depending on the pathology of what you're seeing with your patient. There are several different approaches for managing dysphagia, and one involves muscle strengthening exercises. And if you're having these difficulties, this patient will need to be referred to speech therapy to help assist with the swallowing exercises, but most approaches involve teaching the patient and the family ways to swallow better, usually by sitting upright with the head tilted forward and with that downward tuck a little bit. It can be impacting different types of food consistency modifications to help with swallowing, such as no thin liquids or mechanical soft diet. You can remember all of those things from being in the hospital, but an evaluation is important to determine what these modifications need to be. There will likely be a swallowing study ordered that will show the entire swallowing process and outline if there's any issues or if something may be being held up at some point. So that's an important test to be available for when you make that referral. Next, we're going to talk about some infectious GI disorders, and the first one is going to be gastroenteritis, which we know is the inflammation of the stomach and the intestines, and you may see anorexia, nausea, vomiting, and diarrhea associated with it. It can be chronic or acute, and it can be caused by bacteria, viruses, parasites, or an injury to the bowel mucosa. It can be caused by poisons or organic poisons or medications. The chronic form can be caused from food allergies, food intolerances, stress, or a lactase deficiency. Most often the symptoms and any imbalances in electrolytes are self-limiting in a healthy adult, but can have more serious consequences for the older adult or someone that's immunocompromised. The severity of the illness can be indicated if there's dehydration secondary to a large number of watery stools, or if there's fever associated with it, if there's vomiting, or if there is stools that contain any blood or mucosa. With this condition, it's important to get a good H&P and learn more about if there's any medications or agents that may have contributed to the gastroenteritis, if there's been any organism that may have contributed to it as well. You want to know more about their travel history, any eating out, or any recent antibiotic use. On page 545, there is a table that has organisms that are associated with causing gastroenteritis, and I encourage you to look at that. It goes on for several pages, but it talks about the organism, where it is found, the duration of the gastroenteritis, when it may have onset, clinical findings, and then diagnosis and treatment. We're not going to get into that individually, so just be sure and review those. With these patients, they usually present with nausea or vomiting, diarrhea, fever, or abdominal pain or cramping. Symptoms are often telling you more about the underlying cause, but they also may have fatigue, malaise, anorexia. They may have the urge to pass stool, and then they may have borborygmus, which is that growling or gurgling of the stomach. Often physical exam is normal. In their history, you want to get a thorough drug history, including any over-the-counter medications, supplements, antibiotics, antacids, laxatives, alcohol, or any sugar substitutes, as that could be important in your differential diagnosis. You want to know about travel history, surgical history, how long the illness has gone on. If the patient has severe diarrhea and dehydration, you're going to want to get a stool specimen and look at that for consistency, blood, white cells in the stool. Increased fecal leukocytes in acute diarrhea is indicative of a diffuse colonic inflammation and may be suggestive of an invasive pathogen such as Shigella, Salmonella, or Campylobacter. Other causes of leukocyte positive stools can include your C. diff and your E. coli. Management includes fluid replacement, And electrolyte management. It's important to drink fluids with a sodium content of anywhere from 40 to 75 milliequivalents, such as Gatorade or Pedialyte. For those that have severe dehydration, chronic diseases, or hypotension, hospitalization for IV rehydration may be needed. Anti-motility drugs such as Imodium or Lomotil are most frequently prescribed and are effective in the treatment of gastroenteritis. And there's a table with those on page 553. Another one to consider is Pepto-Bismol. And one last thing, antibiotics are recommended for patients with severe diarrhea, especially those who may have fever or stools positive for leukocytes. Follow-up is not usually required except for patients that they might have concerns for chronic forms of infectious diarrhea, such as those with C. diff. Next, let's talk about hepatitis, which is a very common problem throughout the world. Blood. On page 554, table 39.2, there is a good box that has causes of acute hepatitis, whether they're viral, non-viral, metabolic, vascular, drugs, or toxins. So I encourage you to look at that as well. On page 556, there is a table that breaks down each of the hepatitises and talks about transmission, their incubation period, lab tests that need to be done, immunization, prevalences, and then mortality. Just as a review, there's 4 phases of presentation. There's the incubation, which is typically asymptomatic. In the prodromal phase, you may have a quick or slow onset. You could have loss of appetite, nausea, and vomiting, upper respiratory infections, fevers, abdominal pain. The next phase is the icteric phase, where you'll see the jaundice in the skin, dark urine, light-colored stool. And then it's the convalescent phase, where the appetite returns, jaundice and abdominal pain begin to improve. In management, the key to preventing hepatitis is prevention of transmission and symptomatic relief. Vaccines are hepatitis A is recommended for all kids at 1 year, for anyone that's traveling, where for men having sex with men, IV drug users, and chronic liver issues patients. Hep B is recommended for all kids under 19 that are not vaccinated. Healthcare workers, daycare work. Treatment, regardless of the cause, is supportive, and those with chronic Hep B are those are ones that you would refer to a hepatologist. And the last slide we're going to talk about in this section of infectious GI disorders is an appendicitis. And it's most common between the ages of 10 and 30. Men are considered 2 times more likely than women. It's more common in our Western countries due to high-fat diet and low fiber. Diagnosis of an acute appendicitis is made both clinically and with the input of the patient's H&P. Classic presentation is an acute onset of mild to severe colicky, epigastric, or periumbilical pain that is often vague at first, but within 24 hours usually becomes localized over the right lower quadrant. There are several different advanced assessment skills that you can use in the assessment of appendicitis. Those are on page 563. Be sure and look at those. Those include Roseneg's sign, the SOAS sign, the arbitrator sign, and McBurney's sign. And they'll tell you how to do it on exam, and then comments that will help you better understand. Management of an appendicitis is, of course, going to have the appendix removed, and this will be done surgically. If there are fevers associated, And if there's been concern for a perforation or peritonitis, antibiotic coverage is needed with a third generation cephalosporin. And then if there is concerns for peritonitis, antibiotic coverage for both gram-negative anaerobic organisms are recommended. Preoperatively, as they're waiting to get him with surgery, there can be the correction of fluid and electrolytes, bed rest, and keeping him in PO. And that's going to finish out the first half of section 7. We'll be back for the second half in just a moment. Thank you.